Hi, everyone. I have the huge honor to talk with Dr. Manuel Cornely, Professor Cornely, who really pioneered the surgical treatment of lipedema or uh, or, or lipodolorosa. He really was the first back when all of us other surgeons were afraid to do what he had the courage to do. And I'm going to ask him to start talking about the history of liposuction for lipedema. Dr. Cornely, please.
So thank you very much, Thomas, for inviting me and giving me the chance to talk on my first experience with lipedema patients. It really started in 1992, I think. It was in my beginning my university career in the University of Halle in Germany. I was educated by Professor Marsh, and he was a lymphologist, first-line lymphologist. So seeing these ladies with lipedema and the ladies with lymphedema as well, which is something very different, the idea was, what can we do best to bring them out of the conservative treatment, the lifelong conservative treatment, and the pain. These were the 2 points the 2 aims we are scoping. So first we had to do investigations. We wanted to know what's up with the lymph vessels in these patients, and are they damaged or not in these lipedema patients. And the investigations were done by other guys on an international plan, for example, by Professor Bender as well in Germany, who showed us that these patients had a high volume insufficiency in their tissue. It was Professor Power from the Black Forest area who gave us the first idea on this. So we knew that these patients had pain in the tissue, but they didn't have any lymphological problem, as we knew it from lymphedema. So it must be something else. So we were focused on the fatty tissue disease itself with our simple methods. Coming from the tertiary part of dermatology, I was educated in doing suctions, liposuctions, in cosmetic questions. This was something I was educated by my friend Gerhard Sattler, and I was first had my trainings as well with William Hankey in congresses in Germany, for example. So I started my first method training with patients to reduce the fatty tissue on legs and arms very kindly and very slowly, to bring away the tissue from the lipedema patients out of arms and legs. But we knew the problems. One of the problems was that we are not allowed to do any injuries in the lymphatic vessels itself. So this was a methodological theme we had to change and to solve. You know, using the tumescent anesthesia, which was given by Jeffrey Klein in the 70s, I think, 60s, it was typically it was around about 1 or 3 liters of tumescent anesthesia in these patients and these indications. But in our patients with lipedema, we needed a lot more of tumescent anesthesia per session, because we decided that we would take away the fatty tissue always in 3 sections on the whole body, on the extremities, on the arms and the legs, 1 session for both arms, and 1 for the outer thighs and 1 for the inner thighs of the legs, always completely over the knee and not changing it in another way. So we needed to go on with the tumescent anesthesia, and we found out that we could go up to 10 liters TLA per session and remove and aspirate around about 8 liters of fatty tissue itself. But this did not answer how could we avoid the damage of the lymphatic vessel itself. So years ago, in 2003, I think it was, I went to my colleague Erich Brenner to Innsbruck to the university, and I wanted him to give me a cadaver section. And so we trained what we did for our patients in lipedema in the regions, and we could show that it's necessary to have no crisscross maneuvers in these patients, never, and that it's necessary to have a primary strict superficial aspiration. Why? You're not allowed to take away, you need to take away the fatty tissue in cosmetic indications in a crisscross maneuver in the middle layer of the fatty tissue itself. You are not allowed to do this in lipedema because there you have to take the fatty tissue completely out of there. So avoid any crisscrossing in lipedema patients. Go always strict to the axis of the vessels and don't cross them. If you
I'm
go
gonna interrupt.
Yeah.
This is I have here. I'm just showing. This is one of your
Yes, this was one of the
vivisections
cadavers.
after looking at, and you can see here that the lymphatics are preserved there after this
The suction maneuver.
this lymphological liposculpture.
Exactly. This is a very old figure.
I know. Who is that? Who is that young guy there? I don't know. Yeah.
Yes, I'm the young guy left, and in the middle it's Erich Brenner, and nobody knows who's the cadaver. Okay. So,
yes. Okay. Yes.
you want to talk about this?
Yeah.
We'll talk about this. So
we just want to be clear. The guy was already in bad shape before this started. Yes.
Okay. So what we tried to show to all those who said you are not allowed to do surgery in lipedema was that it's a safe method. The procedure is to be formed in steps, and I want to highlight that even today we do it always the same way. The method starts always with marking the areas we want to do the section. Then we bring in the tumescence anesthesia, which maybe takes 20 minutes. Don't know, it's due to the pump. I like to bring it with a 200 milliliters per minute pump, and then we wait. We want the tumescence local anesthesia to prepare the adipocytes itself. They go into the adipocytes, they correct them. They change it into a gel.
Yeah. Yes. I wanna just echo that, and we allow this tumescent to turn it into a gel. And one of the things is we both do this in our outpatient clinics. In a big hospital, you're not allowed the time to do this. You have to, every OR room has to be making money every minute, and so this is one of the things is you developed your own clinic and your own so that you could do this and allow this to work, and this as you explained that allows more efficient and complete reduction of the tissue.
Yeah. But away from the organization problems and the money-making problems, it is necessary when you do any surgery, you have to have a safety procedure.
Right.
And the most safety procedure for protecting, for example, the lymphatics and protecting as well the patient itself, it's necessary to have this preparation phase. So even my clinic has to earn money. So we have 2 surgery rooms, and for every surgery room, 2 preparation rooms. So we have a roll-on. We take the first patient go into the tumescence, then he goes back to the waiting room. Then the second comes in, then he goes back to the waiting room. We take the first of the surgery, we bring him back, then we do the third tumescence anesthesia, and so we go on. At the end, we always start at 6:30 in the morning, when we finish at 2 o'clock in the afternoon, then we did 5 patients for every surgery room, so we can do 10 patients a day. So even a big hospital is able to plan it this way. And if they want to do it this way, it's possible. But going back to the indication, surgery in lymphatic diseases. It's a lymphatic disease we are talking about, and it needs to be safe treatment so that no lymphatics can have any injury. We could show this. We did our first suctions in 1997 in Düsseldorf, in Lipedema. Düsseldorf in a town near the River Rhine, near Cologne. And we did 140 patients and controlled them after 7 years. This was our first publication to the quality of our treatments, and quite a huge amount of these patients we had before we did the surgery, we did the lymphoscintigraphy. We wanted to know what is the quality of the transportation rate of lymphatic vessels, its quality of transportation rate. And we did the same patients after 7 years again with the same method, and it was the same investigator. So it was again with lymphatic scintigraphy, and we could show, it was published by Bender, we could show that none of the patients had any problems with the lymphatic vessels. And so since 2004, we know that this method does not damage lymphatic vessels. Even the discussion did not stop up to now. It is indeed an important question that you have to do it in the right way. You have to do the surgery in the right safety way. If you go out of this way and you go on crisscrossing something like this, I would say you can damage the vessels.
So I'm going to point out, this is this longitudinal technique that you're demonstrating here,
Yes.
and how it goes along the axis of the arm or leg, and that parallel to that axis. And when you say not crisscrossing, you're meaning not going transverse or against the axis. Yeah.
It is technically maybe a little bit complicated, because knowing from the cosmetic surgeons doing the aesthetic indications, they know that the crisscrossing is a good manner to have a smooth surface afterwards. So this might be, from the technical view, when you just go along to the axis, it's a little bit complicated, but at the end, with some training, it's the same good result. So I emphasize everybody wants to do lipedema surgery to have a look on this non-crisscross long axis down to the facial and complete removing the fatty tissue.
Yeah.
The second part of this method, which I named lymphological liposculpture because it's lymphologic, and at the end with sculpturing as well, is the post-surgical treatment, which is necessary. It's not, oh, we can do or cannot do. You have to do a post-surgical treatment, and it's always over 4 weeks, not more, but 4 weeks. And it starts with the garment in the beginning, the first day, the first night we do the bandaging because it's easier to change. We always leave the stitches open. We have an open drainage of the liquid. We tried anything, but that's the easiest way. Just cover the holes with some compression stuffs that you can take it away afterwards, and that's very easy. You will not have any more water coming out of these areas after normally 3 to 6 days. Then it's dry. The stitches close themselves, don't touch them. And you bring on a compression garment beginning in the first day, and it has to be worn 24 hours a day for the first week. The second, third, and fourth week you reduce to 12 hours the day or the night, whatever the patient wants, but he has to go on with the manual drainage for 4 weeks, 10 sessions, first week 4, then 3, 2, 1. And after this series of, we call it this accentuated manual drainage, accentuate because it's always whole body, but and the focus of the surgical part, it's always whole body, but focus on the surgical part. We stop after this, after 4 weeks, and then you do nothing more. You will have no more pain. You do not need any more treatment consultatively. So under normal conditions, we do 3 surgeries in every patient, stage 1 to 3, and we have every round about 5 weeks due to the hemoglobin the next surgery, round about 5 weeks. Only in patient stage 3. There we have control after we control all our patients after 6 months and 1 year, and we have no problems, no new lipedema or something like this, because it's like an amputation. But only in patient stage 3, we sometimes have a 4th and sometimes as well a 5th session due to parts of fatty tissue which are still painful, because these patients have quite often as well obesity, so maybe you didn't remove anything you needed to.
That's wonderful. You know, it's so wow, that's great. You were really at the forefront, and then other colleagues in Germany followed your lead, and then it's now spread, of course, all over the world. And
yes,
we now know there's all sorts of things that have developed around this. We're trying, we're looking at how to best I've also started looking at how to prepare them best with a diet, and I also believe, we also are we leave our punctures open, and also and very similar protocols with compression, where except I have them wear it for the compression for 24 hours for a full 4 weeks. We make sure they have, several pairs of garments to, so that they can change them. Yeah. But yeah, it's very, very similar. But this is all, it's so amazing that you figured this out, and really, really allow this treatment for women with lipedema. Because before I had this to offer them, I would just offer them compression and dietary advice. And I actually had published a paper about this, and this does help them a little. Yes, you do get some benefit from the compression but it does not give them the kind of improvements in their mobility and improvements in their pain that this surgical reduction has.
So I want to highlight again, doing any treatment, even the conservative or the surgical, needs to have a good diagnosis. So first of all, you have to have the right diagnosis. You have to discriminate lipedema from obesity and all the other things. And when you have a really patient with a lipedema, stage 1 to 3, 1 up to 3, and you know that this is the disease, then you have more than one choice. Starting in 1997, we just had one choice, conservative treatment. That's done. Nowadays, you can have the choice of conservative treatment, surgical treatment, and maybe what you tell us, the way of we have a small improvement as well with some educations, motions, movings, and diets, and so on. But at the end, it is for you to be, as a doctor, to have the best solution for the patient. And it's impossible to say to the patient, I do not do what we can do. Surely you can have a possible good treatment by surgery, and it's always the same. At the end, you need to know what you're talking about. That just me give you a last small joke at the end. I was invited to speak in Denver in 2002 on the question on lipedema. And it was the first time coming to the US, and I was very afraid of talking there, and it was combined with Gerhard Sattler. He was with me, he invited me to go there. And on my way to the stage to give my presentation, there was a colleague coming in the other way. He wanted to go outside. There was, I'm so sorry, but I have to go to toilets now yet. But it would be very amazing to be informed how you do sucking the lips. I would be really interested to know this lecture. So in 2002, this colleague had the idea that lipedema was an edema of the lips. So, you know, up to now, up to today, I think there are huge amount of colleagues who will not know what we are talking about when we are talking lipedema. So it is necessary to have education to doctors, education to patients, to discriminate anything which is not a lipedema, and to focus on what it is. And we have still a huge amount of work in progress, not only in surgery, as well in all these other things in lipedema.
Yeah. Oh, that's lovely. And I find here, listen, I find that I also find there's people who self-diagnose that they have lipedema, and they come to me, and some of them actually do not have lipedema.
Yes.
And so it needs to be carefully diagnosed, and there are other things that can look like lipedema, and other things can cause, large legs and arms, and I've had people with pelvic venous insufficiency that were misdiagnosed as lipedema, people with partial lipodystrophy that were misdiagnosed as lipedema, and of course some that had just obesity, or even other types of endocrine problems, like and they've been misdiagnosed, and so it is important that we are careful about this diagnosis, and it should be done with a proper physical exam and such. Yeah. So
yes, we are improving tools to have better diagnosis without histological treatments. Even those histological investigations are not sure. And we will see what we can do in the University of Cologne at the moment with the Department of Translational Pain with Professor Hugo. But I think we are on the right way to have a bedside diagnosis test in the next years, so that we can really show exactly what's lipedema patient, what's not. It will be a very nice thing to go forward to give the right patient the right treatment. So, Thomas, any more questions?
No, this was wonderful. Thank you so much. I really appreciate it. And I'm gonna sign off, and just thank you, and we'll talk shortly.